ಅದು ಇದನ್ನು ಹೇಳಂತಿದ್ದೆ immunosuppressive protocol ನಮ್ಮ ಬರಲ್ಲ ಕೇಳ್ಕೊಂಡು
Thank you, Dr. Gautam and the chairpersons. Friends, we move on to the first guest lecture of the day to be presented by Dr. Deepak S. Ray. The topic is ABOI incapability transplantation, immunosuppressive strategies for optimal outcomes. May I request Dr. Deepak Chitrali and Dr. Sridhar to please go on to the chair. Dr. Deepak Ray, please.
Good morning, Chairperson sir, ladies and gentlemen. I am thankful to the organizing committee and the scientific committee for inviting me to Coimbatore. Last time I visited Coimbatore was probably in 1980s, long back. So today I'll speak on ABOI transplantation, the immunosuppressive strategies for optimal outcomes. I'll give the international literature and then our own data. We'll discuss on graft survival, patient survival, rejection episodes, incidence of infection, and of course the additional cost involved in ABOI incompatible transplant. The desensitization protocol, as you know, are removal of circulating ABOI antibodies by extracorporeal methods like plasmapheresis or double filtration plasmapheresis, which is more commonly done in Japan. Immunoadsorption more commonly done in Europe. Most of the centers of India, even in USA, we do plasmapheresis. The choice of techniques will be related to the availability, cost, and the comfort with the technique. Then we use immunomodulation. We use IVIG, which replaces immunoglobulins removed during plasmapheresis. It also does complement downregulation, interaction with Fc receptors, inhibits CD19 expression on the activated B cells, as well as that of complement and alloreactive T cells. It inhibits B and T cell proliferation, inhibits CD8 T cell cytotoxicity, and increases apoptosis of B cells. The other drug we use is cell depletion by rituximab, and earlier splenectomy was being done. After 2099, rituximab came into market or practice. After that, rituximab has taken over, and it's a CD20 monoclonal antibody which binds with CD20 on immature and mature B cells and results in depletion. And the maintenance immunosuppressive is similar to the ABOI compatible ones. There should not be any difference in the maintenance immunosuppressives. These are some of the protocols. The Japan, Dr. Tanabe's, they use a relatively higher dose of rituximab, 200 milligram per square meter, 14 days prior to transplant. They use DFPP, and they use basiliximab as induction therapy. They start methylpred, TAC, and mycophenol at 2 weeks prior to transplantation, and then gradually reduce the doses. John Hopkins protocol, they use CMV IG, 100 milligram kg per kg after each plasma exchange. They do plasma exchanges. They had been using daclizumab on day 0 of transplantation, and after that once a week for 4 weeks. But daclizumab, as you know, has been stopped from 2019. I'm not sure what they are using, maybe basiliximab. This is Freeburg University Hospital. They do a large number of ABO incompatible transplant. They use a higher dose of rituximab, 500 milligram per meter square, around a month prior to transplantation. They do immunoabsorption, and they use single dose of IVIG 0.5 gram per kg pre-transplant, and immunoadjustment post-transplant only when required. And the last one is the Mayo Clinic protocol, where they use a higher dose of rituximab, 375 milligram per meter square. They do plasmapheresis followed by IVIG, and they continue ATG. They give induction therapy with ATG 1.5 gram per kg for 5 to 7 days post-transplant, and they do post-transplant plasma exchange of the IVIG in day 1 and day 3. The graft function in the older era were very not good. It was very bad. The graft survival at 1 year was 78%, and rejection was as high as 50%. But from 2000, after use of rituximab and modern immunosuppression, the things have completely changed. The graft survival and rejection rate have been good. And this is from Japan. 3 eras from 89 to 94, the 5-year graft survival was 68%, which improved to 76% when immunosuppressives were modified, and beyond 2001, when rituximab was used, it is 90%. The similar good result in 2000 to 2010 has been shown by Jenberg from Sweden. And this is a study where they have compared graft survival between ABO incompatible and ABO compatible from Japan, from UNOS, Montgomery from US, and they have shown equal result or statistically non-significant difference between ABO compatible and ABO incompatible transplant from 1 year to 9 years. And some of the studies from Japan and Germany, even from Baltimore, have shown, even though statistically not significant, the ABO incompatible transplant can have a better outcome than the ABO compatible ones over a period. The patient survival has been good from different studies, and it is well comparable with ABO compatible ones. The major reason why people have problem is infection. The study from Germany showed viral infections like CMV, herpes, varicella zoster, and polyoma virus infection is more common to be in ABO incompatible recipients. From France, there was a study showing that at least overall infections rate and BKB viremia was higher in ABO incompatible patients than ABO compatible patients. The other infections were statistically not significant in both the groups. This study shows in the first year, the infection rates are higher in ABO incompatible ones, and beyond 365 days, it is comparable with the ABO compatible ones. Again, study from Sweden showed no difference in the incidence of infections. This is one of the latest paper with a meta-analysis of 26 centers study, where they had shown very high rate of infection in ABO incompatible patients. It is 49% versus 13%, which is significant. There was also higher AMR in ABO incompatible group. But out of this, the 17 studies showed that out of 26, 2 studies showed the result with ABO incompatible or infection rates were lower, and 6 studies showed that 7 studies showed that it is equal. So infection prevalent could be wound infection, but that happens if there is a bleeding, and bleeding happens if you are doing plasma exchange with albumin only. At least prior to transplant, you should give for a couple of plasma exchanges, you should give FFP to prevent the bleeding during surgery. It can happen, the UTI can happen, and viral infections like CMV and BKV may be more common. This is our institutional statistics. We do around 30, we started in 2013, and we do around 30 ABO incompatible transplant every year, except for the COVID year where it has fallen down. This is our very simple protocol and cheaper protocol. We give rituximab. If the antibody titer is up to 512, we use 100 milligram of rituximab, and if it is more, we use 200 milligram. We start steroids 20 milligram, tacrolimus and MMF from 2 weeks prior to the transplant. We admit 7 days prior to transplant and do plasma exchange and IVIG. And we give induction therapy with thymoglobulin, 2 doses of 1.5 milligram, day 0 and day 1. Presently, our target antibody titer is 64. If consecutively in 2-3 days the antibody titer is 64 or less, we go ahead and do the transplant. We don't do further plasma exchange. We use FFP because it is cheaper and there is less bleeding. We don't use albumin normally. Over the period, we have tailored our preconditioning. The target antibody titer from 1:8 for first year, then it was 1:32, and presently we are happy with 1:64. The initial prednisolone dose was high, which we have reduced to 20 milligram per day pre-transplant and gradually dropped down to 5 milligram per day. Patients with antibody titer of 1:32 may have just a single plasma exchange. Patient with 1:16 or less, we do not do plasma exchange. We just do the transplant with rituximab. We don't monitor antibody titer except for the post-transplant period unless it is clinically required. And we don't give prophylactic plasmapheresis post-transplant, even if the antibody titer is slightly high, unless there is a clinical requirement. Over the period, we have reduced the dose of rituximab. We started with 5 milligram per body. We reduced to 200 milligram, and now if the antibody titer is 512 or less, we give 100 milligram, and if it is more than 512, we use 200 milligram. Antibody depletion is done by conventional plasmapheresis, which can be done in each dialysis unit. We normally exchange 30 ml per kg, and the replacement fluid, as I said, is FFP. This is our first study published in Transplant Proceedings, where we showed our results in 2016. We also did a short-term comparative study, 1-year comparative study between ABOI incompatible and ABOI compatible transplants, 30 in each group. There in the ABOI incompatible group, there was 1 ABMR, but there was no TCMR, 1 death in each group because of infections. The creatinine had been more or less similar. So also the eGFR. In the ABOI compatible transplant, we had 3 acute cellular rejections, and in ABOI incompatible one, which is HLA-related ABMR. The ABMR, if it by chance happens because of ABOI, is very, very risky, very dangerous. But HLA-related ABMR, which could be treated. And post-transplant hospital stay have been similar. Pre-transplant hospital stay is higher in ABOI incompatible transplants. The infections were also similar. There was 1 death in each group because of the infection. This has been published in Saudi Journal of Kidney Disease. We also did a long-term follow-up. The transplants done between 2015 to 2018 August were followed up and compared with the similar number of ABOI compatible transplants done in the same time, 75 in each group, and the mean follow-up was around 5 years, 60 months. A different kind of relation, and especially spouses, wife were more in number in donation. We have taken all kind of antibodies up to 1:4,000 in this study, and if you see the 5 patients had up to 64 antibody titer, and majority of patients will have 128 to 512 antibody titer to start with. We don't refuse any transplant, any antibody titer. This is a case we reported in American Journal of Case Report, where we have done 8,196 titer, but that's the maximum our laboratory can report, so it could have been more. We have done two cases of 8,196 titer. We also do both HLA and ABO incompatible antigens. If they are there, we do desensitize. This is an interesting patient who came for the third transplant. The first worked for 8 years, second around 10 years. We did it in 2018. Mother was the donor. There was ABO incompatible transplant, plus there was HLA antibodies. And the girl is doing well. She is teaching in a school and recently got married. Coming back to the long-term follow-up, the duration of admission, because we do plasma exchange after admitting around 20.7 days, including pre and post-transplant. Discharge creatinine on average was 1.5. The comparable creatinine between ABO incompatible and ABO compatible ones. There is, at 5 years, the mortality, the ABO incompatible patient survival was 90.7%, and ABO compatible it was 93.3%. It was not statistically different. The rejections were also similar. We had slightly higher SCR in ABO incompatible in this group, but normally we don't see in most of the patients. The AMR and the mixed rejections were similar. The AMRs are mostly HLA related. We had only 3 ABOI related antibody mediated rejections, and in these 3, one we could revive the graft. In 2, we had to do graft nephrectomy. So if ABO incompatible related, ABO antibody related ABMR happens, it becomes very serious actually. The infections in a long-term follow-up is more or less similar, slightly more sepsis in ABO incompatible ones. So how do we reduce the infective complication, reduce the dose of rituximab? We published a study where we prospectively looked at 100 milligram and 200 milligram rituximab for a year, studied that graft function and infection, and also studied CD20 count in a variable period. So we found 100 and 200 for graft and patient survival. Graft survival is good, equal, but there was higher infection in 200 milligrams. So we use 100 milligram in lower antibody titers. We do use low dose of anti-proliferative agents. Mycophenolate we use 1.5 gram and drop down to 1 gram after 6 months. We limit the plasma exchanges because our titer pre-transplant titer has increased to 1:64. And of course, we give long-term prophylaxis with tramaxazole and valganciclovir like ABO compatible ones. This is a paper where we have shown, it's in transplant proceedings, where we have shown in prospectively in a titer of 512 or less, 100 milligram is good enough and has lesser infections. This is a paper which has been recently published. This is a multicentric paper. Dr. Pathak has also a number of patients contributed to this paper, where this is the largest number of ABO incompatible transplant reported, 1,580 transplants from 24 centers. During COVID period, 390 transplants were performed. The recipient mortality was 10.56%, graft loss was 8.4%, biopsy proven acute rejection was 12.9%. You will find mostly people have used 200 milligram or 500 milligram of rituximab. Very rarely they have used 100 milligram of rituximab. So this is the largest data. Safety and feasibility of ABOI incompatible kidney transplant have been reported. Risk of infectious death in early period of transplantation has been shown. There are very few paper on cost. This is one from USA where the cost of ABO incompatible was double to ABO compatible one, and this has been high all throughout the period, in the first year, second year, or third year, because they use very high immunosuppression in ABO incompatible ones. This is a paper from Tanabe's hospital. I actually reviewed this paper. There was a higher cost during the transplant, but later on the costs were similar both in ABO incompatible and ABO compatible. We make it affordable by lowering the dose of rituximab, by doing plasma exchange, not immunoadsorption, and replacing with FFP. We give a low dose IVIG. We have raised our antibody target, antibody titer to be 1:64. Post-transplant monitoring of titer is not done unless it is required by clinical setting. Post-transplant plasma exchange are only on demand, and we changed MMF to 1 gram per day at 6 months, and if the patient is poor, we switch over to azathioprine. So the cost for a plasma filter is 8,000. We use for 5 times. FFP is 500 per unit. We use around 8 FFPs per plasmapheresis. Rituximab is 4 and 5 for 4,500. Plasma filtration is procedure is 1,500 per procedure. So it is around 1 lakh if you are doing 5 plasmapheresis and 2 lakhs if you are doing 10 plasmapheresis. So you normally won't have to do more than 10. In fact, in our hospital has made a package that if 512 is the antibody titer, we do it with 1.5 lakh extra, then ABO compatible, and otherwise 3 lakh extra. So ABO incompatible renal transplantation with plasmapheresis, single low dose rituximab, low dose IVIG combination with standard triple immunosuppression can be performed with excellent results. Results are comparable with ABO compatible transplants, only moderate escalation of cost, no additional infrastructure required. It can expand the donor pool from the family by 30 to 35%. Thank you for a patient hearing.
Thank you, sir. Excellent presentation and very good experience and vast experience of ABO incompatible transplant. Sir, you are using the plasma filter for 5 times.
Yes. Yes.
Reusing almost each patient you are using only. That reduces the cost very much, sir. Otherwise, majority of the patients, their cost is because of the plasma filters.
In each account, you have to reduce the cost because, there are poor, especially in East, we actually, I work with Dr. Setty's hospital. It's a little for moderate socioeconomic status people, so we have to reduce the cost.
And average number of plasmapheresis required for any patient with titer of around 1,000.
There is no definite rule that the higher is the antibodies, you will have more plasmapheresis. Some people from 12 or 1,000 or 2,000 suddenly drop down to 512, but normally they will require 5 to 10 plasmapheresis.
Okay, right. Sir, like I started doing ABO incompatible transplants in 2016. One of my experience, there are 1 or 2 patients where patient developed almost like ABMR or biopsy suggests for patchy cortical necrosis, but their antibody titers are normal and HLA antibodies are negative, and slowly they improved their graft function after 2-3 days, but they settled at creatinine of 1.82. Like any such experience in your?
No, there have been some discussion about the TMA where there is no HLA antibody and ABO antibody. So obviously it is not ABOI related antibody mediated rejection. It's some other complement problem. The majority case they have stopped, in fact, in PGI Chandigarh because of this. Tanabe also reported this, but exactly not known. It's thought to be complement mediated, but whether it is because of ABOI, because the antibody titer is not high, the HLA DSAs are normal, so it's difficult to say, but this has been reported.
So probable explanation, one of the explanation I am thinking may be because like we are taking titer at 1:32 or 1:64, and these antibodies generally they are weak antibodies, may not elicit humoral rejection, but in rare patients like these 1 or 2%, these are pathogenic which are causing ABMR, but we are giving rituximab, antibody titer is not increasing so after, probably that may be the reason, patchy cortical necrosis or ABMR, and slowly they are improving their graft function without any much interventions also.
Could be.
Probably that is also one of the reason for such scenarios in ABO.
Possible. One thing, if they develop C4D, if you do a early biopsy, just to find out whether they are developing C4D. If they develop, their chance of chronic ABMR are less in ABOIs, because that becomes protective actually.
IVIG, you would recommend for all patients, sir, or only with the higher titers? Because it would add to the cumulative immunosuppression, because few centers
Come
are
again,
not-
please, come again.
Regarding IVIG, IV immunoglobulins.
We give to all patients, we give a low dose, we give to all patients because we also do plasmapheresis. you lose immunoglobulin because of the plasmapheresis, we have to replenish it. So that reduces the infection.
Okay. It's open for questions.
Good morning, sir. I am Dr. Jyotish Gopinathan. I come from North Kerala ICRA Hospital. We have a fair bit of experience with ABO incompatible transplants. Our cohort now is about 90 patients, and we are also part of the study that you just showed. My question to you, sir, is again in regards to the use of plasma exchange. So we started off, our program started off with double filtration, and then we changed over to regular plasma exchange. We had to do that because of hypoalbuminemia and increased drain volumes. We see a lot of increased drain volumes in patients with ABO incompatible transplant, immediate post-transplant compared to ABO compatible. Even after shifting to regular plasma exchange, we do see a bit of hypoalbuminemia, rarely capillary leak also. Has that been your experience, sir?
Hypoalbuminemia because of plasma exchange.
And capillary leak like in presentation?
No, we have not. But we replace with the plasma, so we get the albumin. And we don't have any difference of albuminemia because of the leak. We have not at least come across.
And one final question on that. We have changed our protocol from using just fresh frozen plasma to a combination of fresh frozen plasma with albumin for that particular reason. But it's reassuring to see that that's not your experience. Thank you.
Congratulations, Dr. Deepak Ray, for your wonderful work. I think it is highly encouraging for anybody to take up this thing. My question here is, when you develop antibody-mediated rejection due to DSA, donor-specific antibodies, it was found that the rituximab is not so helpful. So many the latest literature suggests that in the traditional case of AMR, it is not useful. But the AMR due to ABO incompatibility, I think we can prevent it. The rituximab is you are strongly putting forward that is the wonderful drug, rituximab. What is the difference? Why do you think that the rituximab is very helpful in ABO incompatible, but it is not so much useful in the DSS due to the donor-specific anti-HLA antibodies?
Well, rituximab here we use prophylactically. We don't use as a treatment. Normally we use the same treatment of plasmapheresis and IVIG like HLA1. But my observation is the ABMR between the ABOIs, ABO compatible, it's higher in ABO compatible. Could be the rituximab given earlier prophylactic. We have not studied it, so I can't comment, but it could be possible that has an effect. It takes around 2 to 3 days for the rituximab to work and 7 to 2 weeks to make the CD20 count to 0. But that could be a possible explanation. The observation is that in ABOI transplants, the ABMR rate is relatively lower than ABO compatible lung. We will be working on that.
I think I must, Dr. Ramalingam from Coimbatore, I must congratulate you for doing ABO incompatible transplants with 1 in 64. It needs a lot of courage to do it. It will be good if you tell us about biopsies if you have done in these patients for any reason, so that the others can also be very convinced that even though you produce 1.1, 1.2 creatinines are not always the correct manifestations of what happens inside the kidney. So it will be useful for others to be convinced that they can take up 1 in 64, 1 in 32. We do not do that. We do not do anything above 1 in 8, sometimes even 1 in 4. Possible that we'll have to change our policy depending on your results. But you'll do well if you also show us any biopsy you have done. Now, coming to the plasmapheresis, and the IVIG, we feel that when we do plasmapheresis and give FFP, that's a very large load of IVIG that itself. So we do not give IVIG after plasmapheresis using FFP. Please think about it. If you sit down and calculate, you are giving much more than what you will give with IVIG when you do plasmapheresis with FFP. And my colleague pointed out that he had a low albumin state and a lot of drain. This is definitely the same experience we have. We have a lot of low albumin state and drain going on for quite some time. And the only way we do is to treat is to give the albumin repeatedly. That increases the cost. Now, coming to the observation about
Be brief, sir, because of lack of time, is there?
Yeah. I'll finish quickly. The ABMR in HLA derived state and ABMR in the ABO incompatible is different because it is easily treatable, the ABMR in the ABO incompatible state, because the accommodation comes on and the disease gets controlled even with minor treatment. The same thing does not happen in the HLA ABMR. Thank you.
Just small comments on each coach, sir.
Yeah.
The 1:64, first one. We have done it over the period. We started with, like you, 1:4, and last 11, 12 years, we have 10 years, we have gradually gone up. And once you do more and more transplants, probably you become a little more courageous and do it. And to us, it is okay, but not a single reading. We at least observe for 3 consecutive reading and do it. Your suggestion of doing a protocol biopsy is well taken. The second one you said about IVIG. Yeah, there are a lot of studies where they have not used rituximab, they have not used IVIG. There are studies for that. But we feel it is comfortable to give IVIG, not only for the plasma contains this, but also it down-regulates the B cell functions. So we have been using, but in a lower dose. The third one is hypoalbuminemia. Majority of our patients will have around 2 to 3 albumin before transplant. It remains so even post-transplant, immediate post-transplant, and gradually goes up. We somehow have not observed that. About the accommodation happens after 2 to 3 weeks when the C4D deposits happen. So initial pages, there won't be any accommodation, and only when there is an C4D deposit in a very early stage, it can happen immediately post-transplant. They will not likely to have ABMR. But the ABMR is uncommon in ABOI transplants. But if it happens because of the ABOI antibodies, then it is extremely severe. That's my experience. Thank you.
Thank you. We close the session. Thank you for excellent presentation, sir.
Thank you, Speaker and the chairpersons. It is our request to honor the Speaker. I request the chairpersons kindly honor the Speaker. May I request our Chairman Dr. Prabhakaran to kindly honor these chairpersons. We are also happy to honor some of the other chairpersons, Dr. Shaista Hussaini and Dr. Prashant Dhirendra. Dr. Shaista and Dr. Prashant, if you are around, please move over to the stage. An announcement to the delegates, we realize that quite a few of the delegates have not received their conference kit. We request all of them to go to the biocandle stall at their convenience and collect it, please.